Okay, this is good. Yeah.
So they have to call in, right? Or we have to call in.
I don't know. Well, I think Sad said he sent the
Yeah,
link.
I sent the link too. Let me give you the link. So make sure we'll call him and see if he'll. Let me see. Yeah. Let's get it. 9816. Okay. Okay. Let me go on WhatsApp and call him. He can send me a message 3:45 a.m. Yes.
3:45 evening.
Yeah, we have 7 more minutes anyway, so we have 7 more minutes.
Yeah.
Yeah, so maybe it'll call. So kids coming in, you say your wife and kids coming in, huh?
Yeah, yeah.
Nice, excited. You're
Yeah.
gonna be staying for a while or just?
Oh no, just like
Just a visit?
2 days. Yeah.
2 days to visit.
They are going to Nigeria, so
Oh, they go to Nigeria.
yeah, they want to get their passport done.
Okay,
Then
you can drive them to Washington, so.
no,
Where you got passport?
well, the American passport here,
Where?
post office here.
Post office. When they go to Nigeria, it takes 6 weeks to get that.
Yeah, September.
Oh,
In Dallas, there is no availability for appointments.
are you serious?
Yeah. So
Wow, that bad, huh?
yeah,
That's not a big city. Big city.
it's a big city here. No,
Big city has its own problems, right?
yeah.
Big city Mahala. Okay, let me send you this detail. Richard O'Brien. It's on WhatsApp. You can communicate with them and just tell them. This is WhatsApp here. Come on this for a second. That that your setup. They can call them and whatever time. I think I sent him the input that's sent just in case, right? You can communicate with them, but you can this because they're working on WhatsApp. You can communicate on WhatsApp just say. And introduce yourself and send, and tell me it was set up whenever at 7 o'clock, 5 minutes. You can give his number. Just, and if you look on the SANS message here, you see the link here also. They sent it.
Not yet. I also sent him the invite link.
Yes, it's like I don't have all kinds of this and then. Hospital, I mean, like a 200-bed hospital.
Yeah, he's here. He's here. Are you gonna handle the mouse or?
You guys can handle it. Good morning. And we're not hearing him. He's talking, but we're not hearing him.
He looks like he's muted.
Let me down his muted.
How do I unmute him?
I don't think he has to unmute himself.
Yeah,
Let me tell him he's muted.
You're the running the.
yes.
You can mute others, but you can't unmute them.
You're muted.
Yeah, just let me know when you want me to change slide.
Yeah.
Mhm.
He's muted. He's muted.
Yeah. Do you run this on any specific software? This is like
Is it
Skype, Zoom?
Zoom, yeah. So when I just go like that, it's just yes. You're muted. Can't hear you. Can't hear you. Can you see
Should
us?
I send that text?
I send it. So I can't hear you.
Maybe you should hold your phone and tell him to check it.
Can't hear you. Can't hear you. Message.
I think he realized if you're.
Message. Can't hear you. Yeah, somebody's trying to help.
Where is this doctor?
That's in Port Harcourt, Nigeria. It's the southern part of Nigeria.
Wow.
Can you hear me now?
Yeah.
Volume, maybe?
Can you hear me now? Yeah. Dr. Yeah, are you there?
Well, we're next in volume. We can't hear you still.
Can you hear me now?
Can't hear you.
Check something.
Mm,
are we using?
It's maximum. I think.
check volume, yeah.
Okay.
But I can hear you loud and clear.
Very well. Okay, very well. Good morning, Dr. Okoye.
Yeah.
How are you?
Yeah, good morning.
Yeah, very well. I have this morning here on my side a few of my young doctors. I have a student, Dr. Aruna, and we have student Dr. Pristo. They are part of my team here in the US, and
Yeah.
Foley is
My
going to.
pleasure. But your background lighting is not too clear.
He said the background lighting is not too clear.
Open that like that.
Is there a way to?
Yeah, we'll make it bright now. Yeah.
Okay.
Okay, put on lights up then. Does that feel better? Can you see me now?
Yeah.
Okay, open it.
But, you know, it's the lightning is not on your face. Perhaps.
Let's see.
Yeah, the light behind. Oh, okay.
That's
But
better now.
your face is not too clear here.
Okay.
Uh,
In the camera now.
The camera is on.
But it's in my face not too clear. How's that feel? How's that look?
it come up right now, which means the light contributed.
Okay. All right, we'll open that one more.
Uh,
All right, very well. So we have a lot to cover this morning. So in terms of overall overview, let's get started. Then we can talk about other things you may have. We want to make it slightly informal, so that way it's educational for your members on ground. And
okay.
if any person has any questions at any time, they can certainly ask or stop, interrupt, so we can, discuss that. So I want it to be interactive as much as we can. When I'm there physically next month, we certainly can do more practical component to it. But this is just an overview. Again, as you well know, I'm very passionate about endovascular surgery and vascular surgery in general. And I'm even more passionate about introducing endovascular technology to our continent on a much grander scale.
Okay, let me say, we have about 3 patients here.
Mhm.
Will it be possible for us to review just the patients so that they can go and then we
Yeah.
do the academic stuff?
Absolutely, we can do that. Yes, let's do that first then. Sure. So once you or so your person present the patients, what the patients have, then we can use them as a means to proceed. Yes, go ahead.
Okay, and okay, which of the patients do you think we can now use for as a demo?
It doesn't matter. Whatever patient you have, just go ahead and present them, and we can see what you have and use that as a training exercise.
Okay, now you remember the last case you did?
Mm-hmm. Yeah.
Yeah, there's a lot of improvement and the granulation, has come up nicely.
Okay.
Are we to use that very patient exclusively to, open the wound, look at all that, and if there's anything advisable to do, we use it for the demo.
Yeah,
But
as a matter of fact, I have a picture of that patient on my slide here, on one of my slides. If I forward it a little bit, forward. Let's move this forward. This slide.
okay.
Let's just use that. Keep going. Keep going. There's foot one. Keep going. Let me bring that up first for you, and we'll be able to see it. Keep going.
Nurses and all that. Everybody should know.
Okay. So this slide can you see our slides we're sharing with you? Can you see that slide here? Can you see?
Yeah.
Okay. So that's the patient on my
At
last.
what stage is this one?
Say it again.
That will be. All of them should come in. Come in, let me introduce you people to Dr. A. Yeah. Come behind me so you can see it. Yeah, Dr. A, we have where is Novo? Because he has actually been interacting. Come closer so you can see. Dr. Obi is here.
Okay, hi. Hi, Dr. Obi, how are you?
Fine, sir.
Yeah, and he actually
The network's a little spotty.
So you're going there next month?
I might go there next month,
For how long?
a week. There's more time to that, no worries.
Yes.
You have to plan that. I go all the time. If you want to go, and then the first time goes October, when we have a big conference October. You have time to plan. It takes a lot.
Mhm.
said to be part of the
Your volume got disconnected somehow.
He's muted again. He's muted again.
Oh, this one's-
You're muted. Muted.
Can you hear me now?
Yes, that's much better. Yes, yes.
Fine.
Dr. B, and who else is that? Who's the young lady?
No, Suchechi is here.
Uchechi, hi, how are you?
Yes, sir.
Okay, very well, okay. There's one person in blue in the background behind her.
Yeah.
Good afternoon, sir.
Good afternoon, what's your name?
Ruth, sir.
Ruth, okay. No, good to meet you. All right,
Sir.
all right.
And, there's an old man here too.
Uh-oh, who's that? Oh, who's that?
Dr. Nobu.
Dr. Noble, you look different today. Oh, how are you? Huh? You look handsome still. How are you?
Yeah,
Okay,
it's good to see you again, sir.
good to see you. Yeah. All right. So anyway, Dr. Noble remembers this patient quite well. This is the picture on the screen. he and I worked about 12 o'clock or 12:30 that night. Remember that morning? Dr. Noble, remember your patient? That's the wound we're seeing in the, before I left last visit. The lady that came from Benin, correct? Yes?
Yes, sir.
Okay.
Mhm.
So what's the current status? Again, this is a wound. When you see a wound such as this, the things that will go through your mind are simple. Number one, is it an arterial wound? Is it a venous wound? Is it a diabetic wound? Those are the three major things that will go through your mind. All right. So
Yes, sir.
I think she at that time, when you have a wound such as this, the most important thing you have to do is first of all, see that you have to save the patient's leg or limb. And to do that, you have to make sure they have adequate circulation. Now, I don't know if you all have a handheld Doppler. The handheld Doppler is the device you use to check the pulse, which is more accurate than using one's fingers. Especially in a person like this, you want to use a handheld Doppler with a little gel on the top of the foot, the dorsalis pedis pulse, and see if you hear a signal. And by the medial malleolus, on the medial aspect, you can also use that to see if you can hear some signals. Some patients may have wounds such as this and have good circulation. And if they have good circulation with bad wounds such as this, it's usually because of an overwhelming infection, either from diabetes or some unusual infection. And in that case, the treatment varies. If the circulation's fine and they have bad wounds such as this, then the key is just to open the wound, debride the wound, clean the wound, and have different techniques to make sure the wounds get better. And one of the things that we can do in a situation such as this is to get a wound vac. Wound vac. It's a wound vac. It's a sponge that we'll put within the wound, and it will suck the unhealthy tissue out and help improve the granulation tissue. So I'll show you. I don't have a picture of that, but I have a patient I did a couple of last Thursday where he came in and he had really necrotic leg, completely necrotic. And my other vascular surgeon community, who was his patient, he was out of town. He wanted to amputate the patient's leg, and just call and tell him no. He wanted to amputate the patient's leg, and I told them that I could. He was out of town, so I was covering for him. So I took the patient's surgery and checked the patient's circulation out first, and he had perfect circulation. All three arteries are open. The anterior tibial artery is open, the posterior tibial artery is open, the peritoneal artery is open, all perfectly open. I'll show you the pictures when I come next time. So he has this wound that ordinarily the doctor would have just cut his leg off. So we decided, no, we're not going to do that. Let's clean the wound, since it's more confirmed that the circulation is great. It had better circulation than an 18-year-old person. So I cleaned the entire wound and then put a wound vac on it. And this patient's wound will heal, and he does not have his leg cut off. So our goal on this patient in front of us is, does this patient have good circulation? And I think Dr. Okoye had recommended, I told Dr. Okoye to do a CT angiogram, which was done. And the CT angiogram in this patient, what we have in front of you, showed that she had, I think, no major flow below the knee. And by the time Dr. Noble and I and the team finished that night, early morning of that day, we had opened 2 vessels. So hopefully, if the infection is not overwhelmingly bad, then with the improved circulation, we might be able to rescue her foot. So I was hoping that that's the case. Otherwise, I knew if I came back without doing anything that night, and I come back 4 weeks later, she might end up with an above knee amputation. The goal is to prevent amputations of patients if you don't have to have an amputation. Remember, amputation, number one, are expensive. Number two, amputation involves lifestyle changing maneuvers. It causes the patient to have depression, because imagine somebody who's walking along having a good life, and all of a sudden they either step on a nail, or if they're much elderly, they have poor circulation that causes a blood clot or plaque disease that makes them lose their leg. It's life lifestyle limiting. For them to even get adjusted to the fact that they're going to have an amputation, it's stressful. So some people can go to deep depression. Okay, what I do, I don't rush to amputate any person's legs. What I do is you have to do the work, examine the patient, check the arteries, figure out how you're going to treat the patient, how you're going to reverse or improve the circulation to such a point that they can restore flow. But
Doctor, let me come in here briefly.
sure.
We have about 4 patients out there. And
Okay.
of course, this is quite an interesting one. Even the way you are starting right now, we don't feel like going out, going to ask anybody to come in here.
Right.
So if we could just see them,
Sure.
talk nicely to them,
Okay.
by reason of the basic investigation to run,
We can do
give
that.
them the reassurance
Yeah.
that when you come over to Nigeria, that the surgery will be done. Just
Okay.
to
Okay.
do that basic one, so we can now sit down to do this is quite interesting, isn't it? If we start now, we may forget that we have some other guys here.
That's fine.
Yeah.
The first one is the woman that she
Yeah.
already done the surgery.
That one actually may be the last
The
because
last, okay.
okay, good news here. You can see she is the one seated here.
Okay.
Yeah. The last surgery
Okay.
has done tremendously well. Lift up your head. That's actually is covered. I don't know when we will let her do the demo, if we can open it up and be able to get all the details.
Okay.
As it starts again, yeah. So what will happen is that let her just stand by, bring this other
So, sir, it's Dr. Noble speaking.
Dr. Noble. Yes, sir.
Yeah, it's a pleasure to meet you again, sir.
Yes, sir. So
Yes.
tell me about this patient.
Yes, she's doing excellently well. We had to do a more extensive debridement for her.
Okay.
To help with the wound healing.
Okay.
Right now, she has formed granulation tissue so excellently well.
Good.
Bleeding is excellent.
Good.
And then, in fact, right now we've gone to the point where we are now dressing with Sofratu.
Okay.
So we're working her up for a possible
Then this we'll get back to
wound
that.
graft.
Just 1 minute.
Okay. Okay.
Then we actually having a very good section with him. So instead of keeping you, be able just to. So can you have a look at the leg?
Okay. Can we zoom it a little bit more? Yeah. Okay. Okay, I see that. Okay.
You can see. No, just the toes.
Okay. So tell me about the how long have they had the problem?
Talk to him. How long has it been?
This particular one is like 4 months, but it's been reoccurring. It's not the first time.
Uh-huh.
Mhm.
Are you diabetic?
Yes.
Are you diabetic?
You're diabetic. Okay. When you walk, you have to stop to rest on account of pain in your leg.
You have pain on the leg that if you walk, you feel the pain there.
Sometimes,
Okay.
sometimes.
Yeah, go ahead.
Generally,
Yeah.
sometimes, not just when I have the sores.
Mm.
Sometimes the feet feel
The source actually affected all of the toes.
Okay. Okay.
Yeah.
Now,
And,
how old is the patient? How old is the patient? What's the patient's age?
48.
48. Okay. Any family history for circulation problems?
No.
No, do you have any family members that do have this type of thing?
No.
Yeah. No family history.
Yeah. Can I see the toes again one more time, please? The toes.
Let me see. Hi.
Okay. I see it. I see it. I see it. I see it. Okay. Well, one of the things that you would find in a person who as young as she is, I can see that, sir. I can see it. One of the things that you can find in a young person such as her, with presenting with a problem such as this would be what we call blue toe syndrome, meaning that a person as young as she is usually should have normal arteries. However, in some rare instances, you can have somebody who has normal arteries, but some area of the artery may be narrow. It could be in the belly area, it could be in the hip area, it could be in the thigh area. So when the blood flows to that area, the blood thickens and sometimes can now throw little clots to the toes. And that can cause one to have the sores or gangrene or non-healing wounds. That's called blue toe syndrome. What she would need to ensure that she does not have any problem with the circulation at all are two things. Number one, either she gets a CT angiogram to put that to rest, or she has a catheterization, what you call catheter arteriogram. The CT angiogram is non-invasive, but the catheter arteriogram is more invasive. For the catheter arteriogram, would have to stick a needle in the artery, make a catheter go up to the aorta, then shoot some dye and watch the dye float down to her feet and see what we have. The advantage of the catheter arteriogram is because she has active sores now. So if we do a catheter arteriogram and we find a problem, we can potentially fix it at the same time. That's the advantage of catheter arteriogram. If she does not want to have a catheter arteriogram done, then doing a CT angiogram will be reasonable. And if we find something in CT angiogram, then we can target the treatment accordingly. So that's the way to handle that problem. In the meantime, local wound care, since she's diabetic, she has to make sure her diabetes is under control and keep every day, check that for morning and evening before you go to bed, because a small wound such as that, you can go to bed looking good. Next morning, it's bad where you lose your leg. So it's important that.
Okay, I have a CT lower limb angiography here.
Okay, what does it say?
It's saying a short segment DVT of the left popliteal vein.
Okay, the DVT. Okay, okay, but okay. What about arterial segment? Any arterial disease?
Oh no, arterial. Just I think this is only the venous segment.
Okay,
Yeah.
that's unusual. They did say that arterial segment was normal, or it just said it was just venous disease that was found.
No, okay, no vascular. Okay, let me just read the.
Okay.
There's a short segment, 9.6 millimeter in the proximal aspect of the left popliteal vein. No area of stenosis abnormal dilatation, no abnormal vascular or collaterals, no plaques, no extreme mass effects. I don't know how vague this report is.
So that at least that gives us some idea that from the arterial segment she may be okay. It just may be a local diabetic wound. So when we come around, we'll take a look and do a few other things to make her heal faster and get good from there. When I come, we'll also take a look at the Doppler signals. If she has good Doppler signals, then we don't have to do anything else. For the DVT, does she have any pain in the calf?
Calf pain. Do you have calf pain?
Pure pain, yeah.
In the calf? No pain?
No pain.
Okay. Well, then, but if she has DVT, though, you have to treat her with Eliquis or something, Xarelto or something to help make sure the clot, because I can look at the CT angiogram. Sometimes we can actually go in, if it's a soft clot, if she was having pain or swelling, we sometimes suck it out. But if she's not having any pain, there's no strong reason to do that. But it could be a local wound problem, and local wound, we can do wound care and make that heal without any problem. So
Okay.
we'll get to see her when we come in, and we'll assess the circulation locally with the handheld Doppler, and then we'll give her a regimen for wound care that'll hopefully make her heal faster.
Yeah, the conclusion of the arterial Doppler here is actually suggesting a scattered calcific non-occlusive arteriosclerosis involving the anterior tibial artery.
Yeah, that's what I thought. Remember, I told you that sometimes you can have circulation issues, and then you can have blood clot that escape from those areas downstream. But what we can do, did she come? Is she from Port Harcourt or someplace else?
Yeah, she's in Port Harcourt.
So when I come in, we need to have that actual film. I need to review the actual film she had done. So I'm real convinced that we don't have to do anything else circulation wise. I'll review the film and we can make sure there's nothing. Sometimes you may have a tiny area of the circulation as the cause of the problem that may be missed. So I'll take a closer look at the actual film and not the report itself, actual film, and see what the problem. So she'll need to bring us actual CD of the film so we can review that with her when I come. Yeah, but she'll be all right. Well, it should not be a problem.
Where is it?
The one I did on Saturday.
They said everything was sending on Saturday.
It's a soft copy. All right.
Okay, thank you. But in the meantime, she needs to clean that area of the feet with soap and water, maybe even Dettol soap and water every day, dab it dry and apply any kind of very small amount of antibacterial cream like Neosporin or Polysporin cream, just small film, but don't put too much of a cream in that area of the wound so it doesn't make it worse, okay? But we'll come with something that will make her heal faster when we see her. And again, she may be a good candidate for the oxygen therapy we talked about. So we can actually take your foot, the one that's involved, put it in a plastic bag, then put the oxygen inside the plastic bag and make it just tight and connect to the source of oxygen. Put her on 4 liters of oxygen for about 45 minutes a day, 5 days a week or 3 days a week, and that will certainly make it heal faster.
Okay.
Yeah.
So we'll take care of that as soon as we're done with the section.
Okay, all right, very well. Okay, you have another patient you have to review?
You have been here this. Hey, at least we're moving in the right direction. It's a portion of it's how many days away. I remind, I think 9th June is still established.
Yeah, I'm leaving on the 9th, and I'm not sure when I'll get to Port Harcourt, but I'm leaving on the 9th. Yeah, so that Monday, Tuesday will be fine.
All right.
Once I get, I'll close it down. I'll make my itinerary and I'll let you know. Yes, correct.
All right.
Yeah.
Yes. All right. I will just you later. So if you want to, if you have to wait for us today, you know, we try to spend a very good time here. So later we'll let you call.
Okay. Thank you. I'll call you in tonight.
Yeah.
Okay. Take care.
Chill this one and we'll let you see this.
Okay, bye.
Are you together? We have a very
Sorry,
Professor. No, he's talking with the US vascular surgeon end of this week. So when we are done, I can take care of that one. Dr. Are you there?
Yeah, I'm here. Yes.
Preston. We have a non-diabetic. A non-diabetic for how many years? About 4 years. 4 years. It should be more than 4 years. How long has he been diabetic? This is not a 4 years diabetic complication. Okay, when you notice it. Okay. We have a case of a non-diabetic, but a little bit a complex situation here because I tried to look at the entire toes. There is almost no nerve, no sensation. I'm talking in terms of the, the sensitivity of the nerves there. And also have a very large, lift up the legs a little, let me see. Can you see? No, not required.
He has a lot of swelling of his right leg compared to.
Can you see it?
Well, edema, yeah. Yeah, I can see it. So he's had this for 4 years? Is that what I hear, or longer than 4 years?
Diagnosed for years. Can you see it?
Yeah, I can see it. Yes, sir. Yes, sir. I can see it. Yeah.
All right.
On the outer aspect of his ankle has a wound. Yeah.
Yeah, and the toes are already looking, I won't call it gangrene, but
They're
just-
looking dusky. Toes are looking dusky.
yes.
They're looking dull. Yeah, dusky. Did you all check his circulation at all?
And the circulation in terms of the pulse, I know when the leg is swollen this way, sometimes to feel the pulse is a little bit difficult.
That's where you need the handheld Doppler. The handheld Doppler will definitely let you know if there's a pulse, no pulse. It wouldn't matter if they have edema or not. So the hospital has to invest in a few handheld Dopplers in the operating room and on the medical floors, at least one each on the medical floor. The advantage of that is you don't want your nurses to be checking the pulses with their fingers, because the nurse will check a pulse and think, oh, that you have a pulse when the patient has no pulse, because they'll be feeling their own pulse. So it's very important that we did. I had that situation with my father, who was I'm a vascular surgeon. I knew he didn't have any circulation, and the nurse in the major hospital in the U.S. was checking. Well, oh, I have a pulse. I just kept quiet. I knew he didn't have a pulse, and eventually he needed a bypass surgery. So it's important to have a pulse check with the Doppler. It's very, very reasonable to do. It's easy to do. It's not hard at all. Little gel, put a Doppler, you can hear the pulse. And if you hear the pulse, and then the intensity of a pulse will tell you that they have a problem. If the pulse intensity is very, very weak, most pulses are triphasic, you go, but if you can, that's biphasic. If you have, that's monophasic. So if you have a monophasic pulse in a patient like this, for example, even without doing anything else, you know they have a problem. Then the next step will be to do the ABI. So now if you don't have ability, you still need a Doppler to check the pulse. But if you have a Doppler check the pulse, you can also do the ABIs, the ankle breaker index, check the blood pressure of the arm and the blood pressure of the leg. It gives you a ratio. The ratio kind of gives you the degree of severity of the lack of blood flow to that extremity. So a ratio of 1 to 1.2 means that blood flow is normal. If it's like 0.9 to 0.7, it's mild reduction of blood flow. If it's 0.7 to 0.5, it's moderate reduction. Anything that's less than 0.5 means they have severe circulation deficiency. So you have to improve circulation, otherwise they might lose their leg. So this gentleman here, if he's never had the first thing to do is to do like an arterial, since he's diabetic, do an arterial Doppler study, just see full arterial Doppler study to see if he has a circulation problem. If he does, then he may end up needing a CT angiogram. If you cannot have CT angiogram, again, one thing you must remember when patients come in and they have circulation problem, you also have to be concerned or aware that they concomitantly may have a kidney failure problem. So a diabetic like this comes in with a wound, he may have kidney failure, like acute kidney injury. So you cannot, if somebody with acute kidney injury, you cannot tell them to go do a CT angiogram, because CT angiogram would worsen their kidney condition. So it's important that we check the kidney function before you send a patient to go get a CT angiogram. If they have normal function, it's not a problem. If they have bad function, they may not be able to get a CT angiogram. In that case, we can get limited catheter angiogram because we can give less contrast and still get an answer if we have to treat. Yeah, but this gentleman, we need the wound cleaned, check the pulse, at minimum get an arterial ultrasound to see what we're dealing with. And he would need what we call a lymphedema pump. It's a pump that will kind of push the fluid out of his leg so the swelling will go down, also make him feel better.
Okay.
Sorry, Dr. This is my bone. Now,
There's also a dislocation at that very ankle joint on the right one.
Yeah, again, it looks like he may have shackled foot. If he did not have any injury, as the diabetes and the wound gets progressively worse, especially if it's had for 4 years, the bone may now get subluxed and they can get deformity of the bone, a condition called Charcot, Charcot, Charcot foot deformity. So, he would need to be put on some protective boot or footwear so the bones does not continue to shift. So he will need some kind of nice, boots that or shoe that's bigger than his foot, so that we can at least protect his ankle so he doesn't hurt himself, because he's at risk of a below-knee amputation if that does not get better, because he may also have osteomyelitis, infection of the bone, because of the long duration of his wound. So all those things will be put into account. He needs an x-ray of the foot to make sure he does not have osteomyelitis. He needs an x-ray of the foot to ensure that the Charcot and x-ray of the foot will show the Charcot deformity also. So he'll need x-ray of the foot. He'll need wound culture to see if there's more than one bacteria in his wound. He will need an arterial ultrasound to see what the status of the circulation. And ultimately, in the meantime, cleaning the wound, debriding the wound, to make it as clean as possible will be helpful. And also, he will also benefit from oxygen therapy.
All right.
Hyperbaric oxygen therapy to the foot.
All right.
Does he have any questions? Does the gentleman have any questions?
You were not understanding. I don't understand this. Sheep.
That's what he's calling this. They call it Charcot food because of this thing that happened.
This about other can be a dad recently about 2 weeks ago. So it affected the.
Yeah. So he has pointed out a lot of things on it. And then this particular thing, we just like, we call it charcoal. Charcoal food. Because of that, it will be shifting away. So you say that even to help you out, you need a sheep that is bigger than your leg that should be able to fix it. Otherwise, the thing will continue to shift that. But the X-ray will give us more information. And also, we were able to find out whether the bone has been affected on what is called osteomyelitis. All right. So based on that, but we also look at the blood flow on this very leg. How good is the blood flow? Which will do 2 types of tests to determine whether there will be hope for this leg or otherwise. All right. So we'll get a thought to give you all the details. Any other persons having nice?
I had an history.
Don't worry, we'll look at all that and show.
Okay, you don't want to.
After now, man, this is more important.
We'll get back to you, sir. I'll come back and use your back.
Predicted it.
I don't know. Some phones in there.
Like to be on crap up here.
US thing.
So the lymphatic vac, what is it just?
It's lymphatic pump. That's the pump that you guys were using yesterday. Remember that pump put in the leg? The pump was put in the
Yeah.
leg.
I heard back.
Dr. Okoye.
Yeah, I'm here. I have a very I have a brother here. Come and sit here. So she are you a non-diabetic? Do you have diabetes?
No, it was
Sit down, sit down.
I think
You have Dr. here, the vascular surgeon.
I think it was Quebec I know when I now with diabetes. But later now they said no.
Okay. He's a non-diabetic, but are you there?
I'm here, yes. Yes.
Yes. He's a non-diabetic, but under control. We are looking, yeah. But he noticed this ulcer. I think I've shared it with you and also shared the Doppler.
Okay,
Yes, which you actually pointed out something also on
Angel.
related intervention.
Okay.
So currently she's with us in the ward
Mm.
and who to be in position to do it. He has a lot of pains also on it, very severe pain.
Small enough, arrested.
Yeah. So that's basically what it is, about 4 months running or more. December.
Yes.
It's about 6 months now.
Okay. Yeah, sounds like yeah, he does have an arterial disease problem that's causing the lack of circulation, causing him the pain. And again, when you have significant blood flow problem from the arteries, it causes the muscles to starve for oxygen, and that's why they have the pain. So he will be a candidate for arteriogram, and we'll see what we can do to make the circulation better so his pain can ease up a little bit. Yes.
Mm. Okay.
Make sure you get X-ray of his foot also to make sure it does not have Charcot or make sure it does not have osteomyelitis.
Okay.
It's always good to also get wound cultures. Anytime we have suspicions of the wound, or when the wounds, always make sure it's cleaned before they get the wound culture. So if you just don't clean it, just get wound culture directly, you'll grow a lot of bacteria in the flora. So, but if you clean the wound before they get culture, then it's more indicative of the most important bacteria or bacterium that's causing the problem.
Mm. Okay.
But I'll be glad to see him and see what we can do when we get there.
Okay. Okay.
In the meantime, you can begin some pain medication though to ease his pain, and also he may be of benefit to give him some silastazole, at least 50 milligrams twice a day. That will help his circulation a little bit.
Okay.
Silastazole, Pleadol, 50
Yes,
milligrams.
and also important to mention because the D-dimer actually was a bit high on presentation. So it's D-dimer is on high on presentation, and then he has been on cleansing,
Okay.
which we intend to withdraw before you arrive.
Okay.
Mm.
Okay. No worries. Yeah, that's
Okay.
fine. So
It's
what's the time space when patients like this come to the hospital? How long do they stay in the hospital?
Yeah, basically, actually, he's not based in Port Harcourt.
Oh, he's
So,
not.
so that's why I wanted to get all the details on his on the plan of the
Plan of action.
plan, so that if they have to go
Come
and
back.
be,
Yeah.
then we'll be able to work around that.
Okay, that's fine. But we'll put them high on the agenda of people we need to take care of because they have a lot of pain associated with them. So we certainly can fix them whenever we come in. Yeah, it's not a problem.
Okay.
Yeah.
Is he also on this leg? This other leg?
ọkwana abụbi ofu mgbe kama na Chukwu mere maka ngwa anyị ụbọchị asị na onye adọrọ na nka ọ na-egbu
Is the same. Did you able to do this of this one, the double of this,
Yes.
or you concentrated only on this one? Did they do the two?
Yeah, normally, anytime somebody comes in with you order a CT angiogram, anything, a Doppler, always do both legs. That way you can compare, because sometimes the leg that appears normal may have worse circulation problem than the leg that's hurting the patient in terms of blood flow. So that way, you know, even if you fix the one that's hurting now, then you know, hey, down the road you may have to do something else with the legs. Always good to get both sides done each time you do it. Yeah.
Yeah.
Okay. Does he have any questions for us?
You can hear him now.
Do you have any questions, sir?
Well, just my question is, I hope, I hope there is hope that it will be cured.
Yeah, he's talking about the prognosis, the optimism.
Yeah.
I said.
Yeah, there's hope. Yeah, no worries. We'll see what we can do to make you better. Okay. There's hope.
it will be fixed, no issues.
And he needs to get good shoes when he's walking so he doesn't hurt himself. Yeah, he's a good.
Okay.
Right. No worries. Tell him there's hope. Well, when we come, we'll see what we can do for him.
No, it was still over there now. We're talking to him. But one of them I said, why is it oh, Mama? All right. Well, so you should organize on the distance so that we can have a good section.
So, can you go and I tackle I have.
It's already been tackled. They has outlined everything.
I'm tackling, but I'm going
Until May for them and no one will be no matter. Yeah, my card had to bunch of like was no consideration. On a chin again, that did not program. Well,
Yeah, let him take the Pleadol or Cilastatin for pain and for circulation, and give some pain medication like whatever pain medication you normally give to control his pain. Then then when we come, we'll take a good do a good workup and see how we can make it better for him. It's not a
what is the benefit you will get from oxygen therapy?
the wound will heal quicker. It might not help the wound heal. That's the benefit of oxygen therapy. It will assist with wound healing, yes.
Okay. Thank you. Well, let's go. Oh, yeah, this is. I don't know, but no.
The name of the drug to help with circulation. Sorry.
No, can now by ABC meeting now. I will come and give you the download of so that if it's something people can go and come back and How do you know?
That's for low dose, and I had doses.
If I'm big brother, I get I said I have to get everyone to know we are them. Okay, where are the other people? They don't see. Okay. Well, you people can get this chair. We've been in a class this way. Is it okay?
Oh, yes, it's fine. It's fine. It's fine.
Huh?
Yeah, it is fine. Yes, sir. It's good.
Okay.
It's good. It's good. Sounds like you have a lot of sick patients in Port Harcourt and the surrounding state.
Okay. The issue is that I told you that it's more or less when you have a round hole, we also meeting a round peg.
Right, correct.
Yeah, I have this kind of followership on the issue of health-related matters.
Right.
Like one of the videos I posted yesterday, but that particular one was on the kidney-related stuff.
Mm-hmm.
Just as this morning, it has had 7,000 shares,
Right.
and 208,000 views in one night.
Wow, that's impressive.
Yeah, so, and a lot. So right now, I think one of the key things I'm actually thinking we will do is to, I see a lot of them, if I use the word poor, it's not too nice a thing, but on average. So I'm thinking if we can have something like a camp, we can get up to 10, 15, 20 cases. I don't know how many hours it will take for us to run it out in 1 or 2 days, but make it something marginal for them so that from their testimony, I will go around the entire district. I'm mobilizing a team that is visiting marketplaces, some major places, because they believe that all these things are spiritual problems. I have to talk them out of it first, be able to tell them about the medical implication and why it is there. And I think it's a huge market we can take advantage of based on the way we're investing on it.
I see. Yeah. So that sounds reasonable. Yes, I agree with you on that. Yeah, very well. Okay. That's so any do we have any more cases? Otherwise we can
I have asked them to stop. There are so many of them.
okay, okay, that's fine.
Even
That's
before
fine.
we started, I was also reaching out a lot on phone,
Okay.
using on video calls
Okay.
from different places, so.
Okay.
But I want today to be a time we should learn one or two things, because most important thing is that if you get this thing done, let my people also know how to handle it.
Right. That the whole idea is to not only provide the expert care, but also be able to train and rebrand your doctors and nurses so that they are aware on how to capture this patients and how to manage these patients. And again, using virtual means like we're doing today, then we're able to move forward in terms of treatment of these patients. We can also
What kind of
we can also look at the wound care option like we're doing most of this wound care today. We can also look at the wound care option. 1 second, please. Hello? Yes. Bye. We can always also use that. What I would suggest, there are twofold in terms of problems. You have the patients that have vascular problems that you must treat. And you also have the patients that have wound care problems that we have to treat. So we need to be able to I can help your institution set up like we're doing a virtual wound care clinic where Dr. Noble and whoever is under him there can see a patient, and based on what they see, once I've trained them enough to what they can identify, it's a venous wound, it's an arterial wound, and based on that, they follow the algorithm for management of those patients.
There's something I want you to actually, this CT angio is that's with what we are gonna do right now. You find that there's a need for that CT. There's a need for the vascular CM that you also need. I would like you to give attention to that and see what we can be able to pick up over there that can, help to get the right report, so that even when we do the CT angiogram here, we can send for you to see the actual picture. Some of these interpretations sometimes may be misleading,
That's
Our
correct.
people have not been so vast in this area.
That's correct. That's correct. And again, yeah, if you have a trusted, I don't know if you have a CT angiogram at your hospital yet. If you don't have one,
I don't.
as big as your hospital is, you definitely would need a CT scanner. The advantage of CT scanner is somebody comes in, they have signs of a stroke. The very first thing you have to do is a CT of the head to make sure it's not a hemorrhagic stroke versus ischemic stroke. So a CT scan, if you do 10 CT scanners, if your average people in Podaco is charging maybe 60, 70, 80,000 naira for a scan, even if you charge 50,000 naira per scan, if you do 10 scans, it's 50 times 10, So it's good for stroke management, number one. It's also good when patients come in with leg problems, you can also get a leg study like we're doing. So your institution is losing a lot of money by sending people out to an outside facility to do the scans. Then they bring the scan to your hospital, and sometimes the scan's not well done. In the meantime, the patient has spent a lot of money with a scan. So if you have a CT scanner, there's CT scanner, it's done. The images can be sent directly to the US, where we can tell your techs can send directly to the US, where we can look at the scan and give you a reading that you can trust. Something that we and I need to work on that. So that CT scanner will be important. And also the C-arm also. I did send you some info on the CT scan, on the catheter, on the C-arm. I don't know if you received them or not. I sent you some. Oh, I sent you several times. I did coordinate with a guy that they
No,
were.
I've not received anything like that.
Oh, I sent several times. I'll send it again. They were reasonably priced and up to date, reasonably priced scanners. Again, I'll send that information to you again because he gave us some good pricing on it. So I will send that to you again, and that's important. Again, certain patients that we know have financial challenges, and if they're stable, not every person that comes in with a vascular problem you need to rush to do surgery on. There's certain people you can, if they're stable, you can watch them on medical therapy. And when the time comes to do an intervention, if we cannot even do a CT scan, if you have a good C-arm, we can then do a limited CT angiogram, like limited catheter arteriogram. In that case, the cost can come down significantly for them because we're not sending them to an outside facility. The money is spending to get a CT scan that's not really good on the outside, to come to the hospital, then we have to redo everything again, makes no sense. So we need to really get a CT and good C-arm for your hospital. But I'll send you info. That's not a problem. Yeah, I'll send you info. Okay. For your team members there, I can summarize what we've talked about today with a few slides, so that way you can see, what you have. If you give me 2 minutes, give me 2 minutes, I'll summarize that for you so we can have a global view of what to expect, and we'll be able to. In the meantime,
If people miss this, and I can't take it from you.
Hello, sir.
Yeah, welcome.
Yes.
Yeah, the only issue here is that, okay, he's on the slide.
Well, he just went to take care of something real quick. He's gonna come back. I don't know. He was talking about this slide. Let me see.
This one.
Yeah, I think you worked on that patient, right?
Yeah.
Yeah, Doc worked on that patient. How is the patient doing now?
Yeah, fine. She came in here this morning.
Okay.
We're optimistic she will go with her legs.
That's good. That's good. Yeah. Are there any questions that I may be able to answer as a medical?
Yeah, okay. Basically today, what we want to do is that, one, we take the first step. What is the first line of action if you meet a patient with a wound or a leg ulcer? And what are the types of leg ulcer that could be presented, and what are their management options?
You want to answer the question?
Did you get that?
Yes, yes. Okay, come.
Yeah. So
I have my fellow medical student here, so he's gonna assist me.
Good morning, my friend.
Yeah, good morning.
I am here working. I'm with Dr. Oye. Only 2 days now.
Okay.
Oh, he's back. Okay.
Thank God, he's back.
They were grilling us.
All right, very well. I had a little patient. I had to
You have wonderful students.
Oh, thank you. We have a lot of it.
Capable of taking over.
Yeah,
once
that's
it's
right.
started.
Yeah, his Abu has been with me already in the past, and he's just starting. When they finish, they're really good. They get real good. I've trained over 2,000 medical students over the years. So yeah. But anyway, so let's do an overview. This will give Dr. Noble and his associates an idea. Let's start from number one. What we should be expecting, how we should be mining our stuff. Okay. So again, I titled this. We could say endovascular. You could say PAD and endovascular toolbox, or what I've said, vascular limb salvage challenges in rural America and Africa, a blueprint for success. Now, next slide. We'll make introduction. We know in the United States of over 10 million Americans have PAD. Worldwide, over 200 million people have PAD related issues. The age groups 40 and above. Amputations in the US alone is over 200,000. You would be surprised that even the US, as advanced as it is, some doctors don't even do all the things I'm telling you. They just cut a leg off, which is a tragedy because it shouldn't happen. Next. Again, typical signs, smoking, a lot of people smoke, especially in West Virginia where we are, greater than age 50, and poor circulation, cold leg, all those things with pain in the limb. Again, the concept usually is, which we'll talk about, when you see somebody with PAD, there's some fundamental things that signs that you must know. They call the 6 P's of the pain. They must have pain. They have a cold like poikilothermia. The most important is pulselessness. They don't have a pulse. And that's the reason why I say you cannot use your finger to check them. You have to use a machine to hear the pulse, or you do a Doppler ultrasound to figure out they have flow. Okay. Then pallor and paresthesia and paralysis. Okay. Okay. Lifestyle limiting factors, again, atherosclerosis, smoking, genetics. We can't choose how we're born, but we can at least mitigate us from getting bad disease. Said not being active is a problem. And diabetes, obviously, which we have a lot in Nigeria, and cholesterol, high cholesterol issues. Next. Again, these are the fundamentals for your team. It's important that when they see a patient, they do a good history and physical of that patient. 90% of the time, you can make the diagnosis from the history and physical. Everything else beyond that, the ankle brachial index, the arterial Doppler, CT, all those other things, that just means to kind of verify our diagnosis. I can look at the patient and pretty much says you have an arterial disease, you have venous disease, within a second. So I want at some point our team here at Save Life Mission to be as skilled, in making this diagnosis. I have trained medical students and peers that work for me, and they think like me because they've seen it over and over and over. So at some point, your team, our team members here at Save Life will be able to do the same. Next. Again, we have a plethora of options to treat patients. And as an endovascular surgeon, I have all those options. The disadvantage in Nigeria is our doctors that don't have those options because of the society we live in. They don't have the complement, so they're limited. So they can either do a surgical bypass or just cut the leg off. So the only 2 options they have, pretty much. So balloon angioplasty, stenting, atherectomy, embolectomy, removing blood clot, hybrid combination of open surgery and endovascular surgery, even open bypass. All those are on the table when it comes to doing vascular surgery. Next. Okay, is limb salvage feasible in rural communities such as in Nigeria? The answer is yes. And we know that because I came to a community that has worse disease than we have in Port Harcourt, or similar disease profile that we have in some villages in Nigeria. But when I came to the community in 1997, they have big hospitals like, Civil Life Hospital in these communities, but they did not have endovascular surgery. So it's nothing new for me. I was able to start an endovascular program and make those hospitals so successful that they can compete with any major center around the world. And now, not only that, do it in one hospital, then after 7-8 years, I moved to another region. They had 0 endovascular products like you have also in Port Harcourt, and I did the same for 4 hospitals in the area. Then I came to Bayelsa and did the same for Bayelsa. Then, then I'm doing the same in Lagos now, and Abuja is another option. And now, when I met you a few weeks ago, my rate in Port Harcourt just went up. So I am willing to try to push the envelope to ensure that we collaborate and make this happen in Port Harcourt for Save Life Hospital. Next. So we did some studies of some of the people we've seen over the years for for limb salvage, just study. And the goal was to improve blood flow to the limbs and prevent amputations. I am really working hard. I've been working over the years to make sure people don't get amputation. I have cohorts like me here, and the threshold for cutting legs is very low. They just cut legs off. You know, I don't think I have patients that are nursing home patients that they'll cut the leg out, they don't walk. No, sometimes you can still save the limb with endovascular surgery without having to put them through too much stress. Next. Again, the 3 hospitals from 1999 to 2022. Next. So we'll be able to define and make this better. Again, the difference between United States and West Africa and Nigeria in particular is the patient profile is about the same. The big difference is availability of treatment resources, which we have even in poor communities here in the US, we have some of those tools available readily. And unfortunately, we don't have that at our disposal in West Africa. So we have to be creative and innovative. We have to make sure our technologists, our schools, train people that can make some of these devices we're using in the US or in Europe. These countries don't have the raw material. They get it from Africa, bring it over here, fix the stuff, and when they don't give it back to Africans to improve themselves, they really don't care about whether or not you get you can treat this patient in Africa. They say, oh, our company does not have Africa in their radar. So we as Africans have to be a lot more innovative and creative. We can't just wait for somebody to spoon feed us. We have to know what we need and then go for it and figure a way to get young talent to come in and figure the things out that we can make our own stents, make our own stuff. So that's the way to go. Okay, cheaper health costs for patients in the United States has occurred because of a concept called office-based lab. So in a patient, like all the patients you've seen today and that you've shown me, I can treat almost all those patients pretty much in a non-hospital setting where they'll come in to the clinical office or clinic. So you see somebody at a civil life clinic. They come in, you examine them, you do what you have to do, you take care of the wound, they go home. They come back the next week, you give an appointment, depending on how bad the thing, you treat them, they go home. Then when they need surgery, you do the surgery, and they can go home within the same day, within 2 hours or 4 hours of surgery, go home. So that's the efficient model called office-based lab model that I've also developed and I'm also working on to improve and make more feasible. So that way you can have your office-based lab people now be directed to the main hospital when it's a major problem that needs to be treated. Next. Okay, so some of the examples over the years of people who've treated, and you can see the numbers. Next. And again, different types of areas of the body you can treat. Next. 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 So this is an example. Okay, I'm in West Virginia in the mid-section of close to the eastern border, and patients come to see me in West Virginia, in a small town, West Virginia, and they come from Texas, New York, Arizona, Florida, New Jersey, as far as Alaska. They seek me out in West Virginia. This fellow you see on the screen had a surgery done at New Hampshire, and he came to West Virginia and he had a problem. So I saw him, the picture on the left-hand side, the doctor in New Hampshire put 2 stents above you can see the stents top and bottom at the knee joint, and you can see a gap between the 2 stents. So he came in, he had no blood flow to his leg. They had it clogged up completely. So you load that little black knob on the left screen, I shot some dye, you can see nothing's going beyond that. The dye is a dark area. So I tried to get in, the wire was going outside the second stent, wasn't going through the true stent. Eventually, we're able to make the wire on the third screen go through stent, put a catheter down below the knee. Next. And just endovascular surgery. And then we're able to balloon, and you could see now flow going through the stent. Then what we did now, I then put another stent to bridge the gap between the 2 stents so he doesn't have that problem again. Next. And at the end of it, this guy has now more circulation to his leg. He had no circulation when he came in at the next. And you could see that he has now circulation. Okay. One of the things also we can do is sometimes people, this fellow you see on the screen is a doctor. It's about in his 70s. He has amputation on one leg already from a different state. So he actually still works. It's a doctor, like I said, anesthesiologist. So he had catheterization, like Dr. Adafi would do a catheterization on the patient, and they put what called closure device to close the artery at the end of surgery. They did that, and he had a lot of plaque in his left groin, and that plaque stopped his blood flow to his leg, to his foot, and you could see he has gangrene of his foot. This guy has healed up completely. He's still walking, has not lost his foot. So we were able to go in and take the plaque out of the plaque. What you see on the left screen is the plaque that came out from his left groin. And what the middle screen, you see a patch, had to sew a patch to make that artery wider after we took the plaque out. That's called hemoshield patch angioplasty. Okay, but again, those are things that we can do to. Sometimes we don't have to do endovascular surgery alone. Sometimes you can do hybrids, little endovascular, little hybrid surgery. Okay, next. Okay, this is a patient who had complete blockage of his artery from his hip to his knee area. And sometimes you cannot do endovascular surgery to work. So I just made a cut below at his knee level, above the knee, and you could see the big flow on the medial is a vein. The artery is just stops right there. You can see a catheter right there. We're able to now, from that area, it's called retrograde, pass the wire up from the knee up towards going up. Next picture. And we're able to make the wire go through that area, and we're able to now balloon and open it up. Next. This patient had blockages on both sides of the artery, and this lady had a significant problem. I think so we're able to, you can see the plaque on the left side, plaque on the right side. This person were able to make wires go through it, and we're able to balloon and put stents and restore flow. The condition for the board exams for young doctors, when there's no flow in the aorta, lower portion of the aorta, and no flow in the iliac arteries, like you see in this patient, that condition is called Leriche syndrome, L-E-R-I-C-H-E, Leriche syndrome. So they will have buttocks pain, buttocks claudication when they walk. They have pain in their thigh area. So that's something that was easily fixed in this patient. So we can easily do that with endovascular surgery. Next. Okay, you can see that same patient now. Now patient has stents. You can see the stents now. It's now on the far right. The area has been completely healed up, opened up, and there's flow going through now. Stents put in the iliac artery and the aorta have a 90 to 95% chance of being open. It's as good as a bypass. When you do a bypass is open bypass surgery in those days. You have to open the mid-belly area, move the intestines away, and sew the graft to the aorta, then make cuts to the groin and do a bypass. It's big surgery. It stays open for 15 to 25 years, but it's debilitating. They'll feel like they've been hit by a train. But with this technique, this patient that you do the surgery can go home the same day or the next day in worst case scenario. Next.
You do bypass surgery?
Oh yeah, of course. Yes, sir. Yeah, I mean, I'm an endovascular surgeon and a vascular surgeon. When we started training, it was open surgery was the way to go. We do open surgery. But when I started my training in endovascular surgery, I was one of the first group of endovascular surgeons in the world to be trained endovascularly. You know, so my trainer, Dr. Dietrich, in those days was very renowned worldwide. And so any person that trained under Dr. Dietrich was pretty much highly sought after. When I finished my training, I had 11 job offers. I just settled in West Virginia because I wanted to define myself and not stay under the tutelage of my trainer. And I just love the people in West Virginia. I've stayed here for the past 27 years. Yeah, but I do open bypass surgery, and I'm a endovascular surgeon. Endovascular surgery is minimally invasive, but sometimes it cannot cure the problem. Sometimes you have to do open bypass surgery. Like the case in question here, this guy here had one leg cut off already, above knee amputation. Then one of my trips to Nigeria, he was admitted to the hospital, and the doctor that was vascular surgeon that was covering for me saw his leg. I did a bypass on him, and I put femoral to anterior tibial bypass, and it clotted, and the doctor was about to cut his leg off. I showed up for my visit. I said, no, we're not going to do that. So this is what he looked like. So I took him to surgery. Next picture. And I was able to do a few maneuvers endovascularly next. and able to restore flow on him. And you could see, right, if you see the picture on the left, you could see where that little dot is. You could see the bypass going to his anterior tibial area after I reopened it. And that's the same foot, same guy, same foot now, all healed up. So see the difference. This guy would have, he had an amputation, mind you, on his right leg above knee already. He's walking with his amputated leg. He has prosthesis. And that's the advantage here in the US. If I do an amputation, I don't like to do amputations, but if I do them, but I minimize amputation. If my patient has the amputation, in 6 weeks from the amputation, they will be able to walk. You know, if they're walking before, in 6 weeks from their amputation, they will have prosthesis to be able to walk. And I do real good amputation when I need to do them, but I don't like to do them. I try to save them. If I have an amputated this guy's left leg, like the doctor wanted, this guy would have double amputations. You know, he's still walking around, he's still alive. You know, his wound is healed. Next. Okay, this is a case where without retrograde, I go from below on the picture on the right. You put me on the left, you make a wire go up from popliteal going up. Then after you finish, you open the artery. This is an endovascular combined with open. So that's a hybrid procedure. Next. Again, then we then look below, going downstream, make sure the flow below, because what gone up from the where that spread of the metal is going up, we already done that on the last screen. Now we're making sure it has flow going down his leg and there was adequate flow. Next. And next. So this is the same guy looking good. All right, so okay, sometimes in Nigeria we have patients that have blocked arteries in the veins and arteries. Sometimes they have it and we have to know that they have it. And again, if you're identifying somebody with upper extremity problem, they have pain in upper extremity, again, you have to check the pulses. You know, do they have a radial pulse? They have an ulnar pulse. If you can palpate the radial pulse, that's good. If you cannot palpate the radial pulse, you cannot palpate the brachial pulse, they have a problem. Like this patient has
do the patient with the subclavian stenosis, how do they present?
pain, cold hand. In this particular case, this guy had cold hand, painful hand. And again, if it's something that's chronic, they can lift the hand up and even comb the hair, reach over a cabinet. But in this case,
most time it's not arthritis related.
Oh no. So anytime somebody comes to you and they have pain, you always have go through the scheme. Is it arterial? Is it venous? Is it bone? Is it nerve? You always have to think that all the time. So anytime you have pain in the upper extremity, pain in the lower extremity, your index would be most important thing is for them to lose that arm or leg, they have to have no blood flow. So if they have pain, do they have a pulse? They have a pulse, you're good. If they don't have a pulse, then you got to figure, oh, I have to do some kind of test to make sure where the blockage is, because I need to do something. And if you find a blockage, then this is something I treat with endovascular technology or something I need open bypass surgery. So those are the things that they need. If the pulse is there, you check the vein. If the veins are good, then maybe it's the bone. Did they fall? Did they have a broken bone? If that's okay, then it could be nerve. So that's the way you
which of the pulses do you check?
The radial at the wrist, the radial pulse. The radial pulse is the easiest one. The radial at the wrist. The radial pulse is the easiest one to check first. Radial, ulnar, brachial above the elbow area. Those are, if you can fit those, you can palpate usually. Okay, if it's missing, then you use your Doppler to see if you can hear it. If the Doppler just then it's low, it's not there. Then you know that it's missing. Then you have to get a CT.
What is the size of that Doppler? Is it usually big or something you can put in your luggage while coming?
Yeah, something you can put in luggage while coming. I'll have my doctor bring ones for you so you can see one now in a few seconds. But this guy, Dr. Abu will bring down your seat now. But again, this guy, you can see the missing segment. You don't have to be a rocket scientist to see that the picture on the left has a missing gap. See, that's the brachial artery going up to the axillary artery, then it's missing area. Then you can see subclavian. The middle picture, see now, you see a wire is going through the blocked artery. Then the third area, you could see that we're doing balloon angioplasty to improve the flow, you know? So that's how you look at it, advance it. Yeah.
May I just have an understanding about
this is Doppler. This
Oh,
is
no.
Doppler right here. Can you see it?
Okay.
Okay, now give me a low gel. Give me a low gel. Let me demonstrate for them. Yeah, we'll demonstrate a Doppler. So when you have a Doppler, you turn it on. It's a power button. You turn it on. Can you hear the signal? Can you hear it? Okay, but now when I put the little gel on my wrist and I put a Doppler here, you hit up in a second, we'll get a gel. You can hear a pulse. I'll demonstrate in a second when Abu comes back with a gel. But you need this in ICU, you need this in your surgical suite, and you need this on the medical floor. So whenever your nurses are checking a patient's pulse, all they need is this to check if they have a pulse. Okay, and it's better than using their fingers. This will tell you. If I listen to this pulse, I can look at the patient's pulse with this, and if the intensity is very good, I can say, well, you don't need a CT angiogram because it's good enough. You know, I can treat your problem because I can hear enough blood flow going through your legs. Yeah.
Yesterday was the first time I ever used it.
Very simple. Okay, very simple to use. We'll demonstrate in a second. Again, so then the picture on the left, you can see the blockage and see when we finish on that same guy, we put balloon and we open his artery and on the middle picture, and you see everything restored. Then on the third picture, if you look closely, after I finished and I release the band, you can see the blood flow because my incision was made at the level of the elbow, the brachial artery. You can see the flow pushing now. Before I started, there was no flow at all, zero flow. But when I finished putting a balloon in the stand, now you can open, you can see the blood flow nicely. Next. Okay, now this patient again, with the blocked area. This is very interesting patient. I did a bypass on him in 2018. A 66-year-old gentleman. He comes back with right leg pain, and his bypass is clogged up. If you look at the picture on the left, on the far right, rather, you can see two knobs. You see bigger knob, that's this bypass. The middle knob is this original artery of this gentleman that we did not do surgery on before. So now there's a newer technology, it's called shock wave angioplasty. It's like intravascular lithotripsy, like you do the blast stones and kidney stones. So it's the same technology we use to improve flow to the leg. So in this guy, I was able to go from his left to right, and I was able to, I said, well, I can reduce bypass, which is a big surgery for him, or I can open his native artery. So I was able to enter his native artery, next picture, in the middle area, and I was able to pass a wire through that. See, the wires now it's going to native artery. This is native artery, and we're able to restore flow. We did not have to do this bypass again. We're able to use the shockwave angioplasty to improve flow for this guy completely. Next.
This Doppler is the same as Vita Doppler.
The handheld Doppler it's kind of similar to a fetal Doppler, but the tip is not as big. The fetal Doppler, the probe, the tip is wide. This is very pinpointed, but it's the same concept. If they want to just exact same, that's all. That's that you can see it again. Okay, but the fetal Doppler, the probe is much bigger than this one here. Okay, all right. So this again, this is somebody we did surgery on. Better flow. Next. Okay.
Coming in on the surgery aspect, the last procedure you did, or the both of them, what we have in terms of instrumentation, what are the areas you will expect us to improve upon? I would like you to also update us on that, so we could be able to get a more robust system for you.
That's fine. We certainly will walk to that. Where's Francis? I left from instrumentation when I left that I brought with me, so I left it there. So Francis, I left with Francis, and we can certainly build up the necessary tools to build a vascular for open vascular surgery. That's an easy project. It's not that difficult. So this is Doppler. I've put some gel on the Doppler now. So I'm gonna check my radial pulse. When I put this down, I turn it on, and you could see if you can hear it. Can you hear it?
It's just very mild.
Can you hear it?
You can hear it.
Yeah. Can you hear it?
Just a bed fence here.
But that's the radial pulse, okay? That's the radial pulse. That's all you need to get a pulse. If you want to do a brachial pulse, you go
Does
up.
it give you the reading?
No, some do, this does not, okay? If I want to go to brachial artery, I can go right up here and check the brachial artery.
Are you sure that you don't need a vascular intervention? We're not getting it.
No, I can hear it. I can do it myself. That's right, doctor. Okay, but I'm good, okay? So anyways, that's what you need to check the pulses on the patient, okay? So now the picture you see here on the screen right now is the patient that I took plaque out from the patient artery.
On the vessels?
Yeah, from the artery, from the groin. Okay.
Wow.
Yeah. Next bit.
You got it, Christopher?
Yeah, I got you.
Okay, so this is not a limb salvage case, so similar to what you see in Nigeria, but this patient also had kidney failure, you know. Again, he had complete blockage on the CT angio of his superficial femoral artery and the popliteal artery. Next. So that's what you see in that picture is gangrene of the heel, okay? Again, this patient, as I think she's 68 years old, she's had an amputation on the left leg. The doctor, that's when I went to Nigeria at my last visit. When I came back, she was admitted in the hospital. The doctor wanted to cut her leg above the knee again. I said, no, she's a known patient of mine. I'll see what I can do. And she was crying. She refused. So I eventually did some work on her. She still has her leg. Next picture. We're able to do some work. See, I made a cut there. They put a wire up in the middle picture. Next. And we're able to restore, did some balloon angioplasty and we're able to improve flow. Next. Next. So this is a lady from Nigeria, the lady from Benin. Next. Next, you see on the left is, I go back one. You see this left, you see the blockage on the left and see the balloon angioplasty on the right. That solved the problem, okay? That's angioplasty. Okay, this guy, you can see this guy's foot, his right foot looks kind of bluish looking, you know, purplish bluish looking, and his left foot is normal. So when you see that, that's a typical ischemic looking foot, okay? This guy had no pulse in his right foot, had pulses on his left foot. So what we did a testing, and we found on a CT angiogram, we looked very carefully right above his knee, there's a missing segment. And that way he was throwing blood clots from that segment to his toes, called blue toe syndrome, had very painful toes. So what I did was go from the left side to the right side, and we have a machine to suck the clot out. And next picture, we're able to suck the clot out, and the picture, the blood clot went away. And his foot was better. This is an interesting case. She had a lot of pain. She had burn injury at a young age, so she has pretty much crippled arms and feet. But you could see the right iliac on the left screen has blockage. We ballooned that, and the aorta itself, that the big balloon on that you see in the middle, as the aorta had some disease, I was able to open that, and you see a big stent I put in the aorta. Okay, so that helped. Next. You see the balloon aorta, and that helped the patient. This patient here, the middle screen had some tight blockage there. We fixed that, and she felt better. Next. So those are example angioplasty. So again, in conclusion, limb salvage strategies are feasible in medical underserved communities. We have to have creative thinking outside the box for us to be successful. The office-based lab concept is an option. Virtual endovascular surgery development options should be looked at, just like we're doing now with your hospital. And I'm in the US, Nigeria, and we're able to go virtually, and we can train, rebrand your doctors to be able, and nurses to be able to provide care. Especially wound care is easy to do, and that's not difficult to do at all. Again, effective intercontinental collaboration is essential to improve endovascular vascular technology and bridge the gap between the USA and Africa. So that's it for today. And any further questions? That's it.
All right. That's a very, very, at least we can understand where we're going right now. And to a very large extent, I want us to put a summary, and the summary we have, at least a take home for today, is one, simple approach on wound care, like we doctors or the patient or any of the nurse seeing this patient for the first time, presenting this. How do we distinguish between the atrial and the venous ulcers? And second, also, the treatment option, that's the wound care options. And that will go a very long way. That's, you promise us on oxygen hyperbaric therapy.
Yeah, let me demonstrate that oxygen stuff for you. I took a picture of a patient yesterday. Okay, so if you can see this, I don't know if you can see it now, but can you see this? This is set up right now. Can you see that?
Let me bring it close. Is there any demo or video or such that we can share?
I can do that. Maybe I'll do as a video and share with you later. How about that?
Okay.
I'll do a demo video on a live patient here later on, and I will then send it as a video, so it'll be easier. But anyway, again, you're right. What I want to do is what I want to do in summary again is to there are two steps to the problem. Number one, a virtual wound care service. That's one. And number two, the endovascular / vascular service. So there are two arms. Okay. The arm that's easier for your team to handle initially is the virtual wound care option, because I can from here train your people on how to identify an arterial wound, venous wound, diabetic wounds, and how to manage them. So what I will do is what I'll call the ABCs of wound care. Okay, ABCs of wound care. Let me see if I have the information for you. Yeah. The ABC of wound care requires the following. Number one, the patient is in front of you. You have to know the fundamentals of wound care. Initially, you must decide if the problem is acute or chronic. Most wounds that are present for less than 4 weeks are considered acute. Any wound that's present for more than 4 weeks is considered chronic. That's the first step. Okay. Under acute wounds, you can use hydrogen peroxide on the wound, of acute wound, within the first 24 hours. After 24 hours, it's not advisable for you to use hydrogen peroxide. Okay. For chronic wounds, it's not advised for you to use hydrogen peroxide. 1 second. Hello? Yeah, 5 minutes. So again, the various wound etiologies or causes, again, arterial.
Well, the essence of the implication of hydrogen peroxide is essential tissue damage.
Correct. It's hydrogen peroxide on a new wound is not a big deal, but on a chronic wound, it causes tissue denaturing of tissue, so it's not healthy for chronic wounds. Yeah, that's correct. Tissue damage. Again, the various just tell them I'll be out in about 5 minutes. 10 minutes. Various etiology: arterial, venous, lymphatic, neuropathic, diabetic, traumatic, such as gunshot wounds, penetrating wounds, blunt trauma, pressure-induced wounds, and cancer wounds, abscesses, osteomyelitis, those are things that various wounds etiology. Okay, we need to be able to identify from our history what we think this patients may have. So if you have a handheld Doppler, you can, when the Doppler says, oh, you have great pulses, so it's not arterial. You have big veins in the leg, and it's not an arterial problem, and it's more a venous problem. Your veins are normal, your arteries are normal. That's not an arterial problem, it's not a venous problem. You have large swelling in the leg, it's probably a lymphatic problem. Okay, then the arteries normal, veins normal, lymphatics normal, and bones not broken. It's most likely a nerve problem. That's the way you identify you narrow down to the most likely cause. Everything's normal.
If I come in here, if I come in here, is there any intervention in lymphatic issue here? Like,
Yes. Yeah, the most lymphatic wounds can be treated with compression therapy, and there's a pump called lymphedema pump that we sometimes can put on those legs to pump the fluid and lymphatic fluid up so that when the swelling goes down. So those are the things that when the vein, I don't like to do surgery on lymphatic.
So in other words,
go ahead.
Okay, but what it means that those elephantiasis can be managed.
Yeah, some of that can be managed with lymphatic pump. Yes, yes. The lymphatic pump. What happens with elephantiasis and all similar type problems is the lymphatic channels get destroyed. So the lymph fluid does not ascend from the ankle to the knee to the hip back into the chest to be drained out. So so we have a lymphatic pump. The pump continues to push the fluid and it makes it more efficient for them. And that's something that hopefully we can.
Is it a lifelong treatment or temporal management?
Well, the lymphatic pump, what we do here in the US, somebody has lymphedema, we do lymphatic pump and they will stay on the pump. And they usually come to the office and we put them on a pump and they come 1, 2, 3, 4 times. If we see the pump is helping them, sometimes we make arrangements for the company that makes the pump to now provide them a pump at home. So they use the pump at home daily for 1 hour daily, and we get remarkable results with that. Yes. But sometimes you may require surgical intervention if they have massive lymphedema related problems, massive issue. Sometimes you may have to resect the area. Yeah. So the next step again would be the algorithm for your wound care. Okay. Again, the algorithm talks arterial, history, physical, pulse check, ABIs, arterial ultrasound, CT angiogram, catheter, arteriogram. Significance of the ABIs we talked about. If you have an abnormal CT angiogram, you have to refer to your vascular surgeon. Okay. Now for venous wounds, again, venous wounds twofold. You have to decide if it's a venous insufficiency problem or if it's due to DVT. Okay. Again, lymphatic problems with massive edema. You can also see similar presentation in somebody who has DVT of that extremity that was not appropriately treated. So if one has DVT, it wasn't treated well, then they can have massive swelling of that leg, even weeks, months, years after, and that's called post-phlebitic syndrome. Okay, nowadays we have technology to see if somebody has DVT in the leg, we can treat them within a reasonable period of time that they don't develop the post-phlebitic syndrome. If somebody comes with DVT on the leg and I see them immediately within a week of that presentation, if I'm able to treat them, I can restore that flow to a normal state that they don't have the swelling associated with that. And I've been doing that for the past 27 years without any problems. We give them thrombolytic therapy. We have machines.
Is there any surgical endovascular intervention in DVT?
Absolutely, several. I do them routinely, several. And now when I come to Nigeria, I will show you some examples of that. Yes, there is. So you can have a patient who is of childbearing age, maybe 21. You can have somebody who is 80 years old, you have somebody who is 60 years old, they can present with DVT at any time. Now, if somebody presents to your hospital with DVT, let's say one leg is swollen, the other leg's normal, and you can ascertain from your history and physical that this something happened within a few days or even a week, and you do venous ultrasound and you confirm the patient has confirmed DVT. What you can do is put a patient on heparinochelexin like you do in Nigeria. That's okay, but that does not solve the problem because it only the blood clot still stays within the veins, and veins have valves, so the blood clot would destroy the valves, and because the blood clot stays within the valves. So after a period of time, even though they feel better with the pain from DVT, but the valves have been damaged. As a result, the leg keeps swelling like they have lymphedema. So that's the reason. So what I do, and I've been doing past 27 years, is they come in and have known DVTs within a week or so. I'll put an IV in the foot, and I'll then confirm it with the venogram. If it's confirmed that they have a DVT, then I'll put them on thrombolytic therapy, TPA, for about 12 to 16 hours. Sometimes if it's fresh, if they show up within 1 or 2 days, the TPA will either clot out or gone, and by next day it's gone. So the problems will go away. Sometimes that's not enough. Sometimes we have to have a machine to go directly into the clot and suck the clot out. That is a machine called angiojet. Well, another machine called penumbra. You can actually move the catheter into the clot and suck the clot out. So we'll do that routinely. Sometimes they have blood clot that escape to the lungs, and that's a big issue again. Sometimes the device that can go in and actually suck the clot out of the lungs and take them out so they don't suddenly die from PE. So those are things that can be treated.
Well, that sounds very interesting.
Yeah. Again, now if the patient have DVT, we can treat them. Treat them like I just mentioned. If the patient have varicose veins that are huge and they having pain, have ulcers not healing, we sometimes can disconnect some of the veins. That's a procedure called phlebectomy that I sent you information on. It's like
I just acquired the laser machine.
oh, you did. Okay. Well, what brand and what kind? You know, they're different types. You know.
Yeah. Actually, it has. I don't know much about the details, but
I will take a look
can,
at it. No, I'll take a look when I get there. No worries. Okay, but neuropathic wounds, again, descended from EMG, evaluate feet for Charcot because when they're diabetic, they have neuropathy, they have Charcot for deformity as a consequence. That's when the X-ray will be important to define that. Lymphatic wounds will control the lymphedema, treat source inflammation. The most lymphatic wounds could be different: inflammation, infection, radiation. So you got to find the source and treat accordingly. For diabetic wounds, you have to make sure their A1C is better controlled. Then because diabetics can have sudden limb loss. They go to bed with normal leg. They wake up the next day with necrotizing fasciitis where you have to cut the leg off. So it's important for them to be able to be educated to look for those things. And sometimes people have paraplegia or quadriplegia from a motor accident. They can easily develop decubital wounds or pressure wounds, and there are ways to manage these wounds. One of the big things that you can do for your wound care center at the hospital is have a wound vac, where when patients come in, all the patients we've seen today, if you have wound vac on their wounds, you put a wound vac, they can go home and they will do well. They'll come back, change the wound vac every so often, and it can make the wounds better.
Do they have to go home with the wound vac?
That's correct. The wound vac, they have to go home with a wound vac. Again, you can have a situation where you give them wound vac and enough supply for them to last a week. So they go home, and when the supply is being, they have to come back. So for you to evaluate it. Then if you need to put a new wound vac, you put a new wound vac and then go home again. So those are things that wound vac is a great investment in wound care, and we'll certainly work that out. And again, fundamentals of wounds, anytime you have wet wounds, you have to wash with soap and water and saline, and debride the wound with scalpel, scissors. There's a machine called.
What type of soap do you have to implement? What type of soap?
Any kind of antibacterial soap, liquid antibacterial soap. Any type that's antibacterial soap, liquid, that's always good. Don't use bar soap. it has to be liquid. Antibacterial. I will use dial soap, Dove soap, any kind of, and the Dettol you all use in Nigeria is actually very good for that too. You have to have wound culture. Anytime you have wounds, wound culture, and always treat the wound based on the culture. Don't just initially when they come in, it takes a few days to 5 to 7 days to get a culture report. But when they come with bad wound, start them on the broad spectrum antibiotics. But as soon as you get a wound culture report, then you can make sure the antibiotics you're giving them is working well. If it's not, you can make an adjustment to switch to something that works better. And there are a plethora.
You are very correct indeed, because in most cases, we just go and begin to give them Meronel, or at the end of the day, womb not getting better, as if you are giving her the best shot you have and there's nothing working.
That's right. Again, resistance. So again, before you culture the wound has to be cleaned. If you can debride the wound a little bit before you culture, it makes sense. I will usually debride the wound, wash it, rinse it with saline before I even culture. So I'm not growing all the bacteria in the world. But again, there are a lot of wound care products we can use. Silver nitrate, Aquacel silver, Silverdine cream, iodoform packing, calcium alginate, collagen. There are a lot of wound care, wound vac, all those things that are used for wound care. I think the picture you sent me earlier today, that's in at 3:45 a.m. my time. But first wound, that wound can easily be cleaned with what called the Visojet machine. It's the machine that uses water. It debrides the wound and it will take all that unhealthy tissue out. Like all the patients that I've seen, if I have a Visojet machine, I clean the wound, it will take all the unhealthy tissue out. It will look nice and clean and red. Then from that point on, you have a clean wound. Then you can start doing your wound care products to make it work. So again, the ABCs of wound care is very important for us to get there, but it's easy to do. Those are the fundamentals of wound care. And what I will do, I will develop an algorithm for your team, so they will follow the algorithm based on the algorithm: arterial, venous, lymphatic, pressure wound, diabetic wounds. And once they make the diagnosis, they can just follow along as to what they do next based on that. So I was saying, when that come, I'll share that information with your team.
All right.
Yeah. Okay, so those are things. Again, nowadays we don't do skin grafts, so don't let your doctor start doing skin grafts on patients. It's not necessary. Nowadays we have skin equivalents. You can get skin from the pig or from a cow that you don't have a thick skin graft on the patient, cause more pain. It's come laboratory, it's the package. They can stay on the shelf for 5 years, no problem. You put that on the patient's wound after you've cleaned it. After there's no.
Do we have to kill the pig here, or is something that's already processed?
It's processed. It's processed. It comes in a little paper. It comes in like a little thin piece of paper, and you just clean. Once the wound is clean, there's no more infection in the wound. Then if you have good granulation tissue, you can put that skin on it, and that's it. It will facilitate the wound in healing. So you don't have to go have a doctor say, I need a plastic surgery, I need to do a skin graft and take skin from patients out of the leg and create a more pain, more wound. So that's the way. I've not done skin grafting in, I'll say, many years, because I have the ability to use skin equivalents now. Yeah, but the wound vac is a great tool to help bad wounds get better. Again, if you have a lot of drainage in the wound vac also is a good thing to suck all the fluid out. So those are some of the things that we do.
Sorry, sir. When you use the bovine equivalent to heal for the skin graft, how long does it take to heal?
How long does it take?
Yes, sir.
For the bovine equivalent.
How long does it take?
Yeah, well, what happens is it does not work like conventional skin graft. What that does is, once you clean the wound, you put it on, you cannot touch that wound for about 7 days to 10 days after you put the graft, because the graft will now disintegrate into the wound. Then it has some growth factors that stimulate healing. And sometimes that patient may have to come back after 7 to 10 days. You take a look and see if it's doing really well. Sometimes you may have to put another graft. And within 3 weeks to 4 weeks, a wound would heal. Mostly if it's a healthy wound, has good blood supply, you can heal that within 4 weeks.
Okay, sir. Another question, sir, if it's possible. for the hyperbaric oxygen therapy, is there any way we can do an improvised one in Nigeria?
Oh, absolutely. That's what I was saying. Now, one picture I was showing is you just take a plastic bag, take a clear plastic bag like a garbage bag, clear, clean. Okay. You get your oxygen source, like the nasal cannula. You put a nasal cannula on the wall, whatever your oxygen tank, right? Then you put the patient's leg in the plastic bag. Then you put the oxygen, like the one, the bridge that will go to the nose in the can, right? Then you then take some tape and tape it real tight against the leg so it's really tight. Okay. Then you turn the oxygen to 4 liters. That's it. The bag will expand. Make sure that there's no hole. Make sure there are no holes in the bag. The bag, if there are no holes in the bag will expand, and then the patient stays there for 45 minutes. That's it. You know, it's very easy.
Okay, yeah. You get the bag filled up, then you stop.
Yeah, give 4 liters, and then patient sits there and make sure it's sealed, and put a bag in and sit there for 45 minutes. That's all. Okay.
Okay.
Yeah,
Okay,
but
no,
it's easy.
but where you put the okay.
So say the oxygen, right? You have the
Yeah.
oxygen source. The portion goes to the tank, and then that source goes to the patient's nose, right? The portion that goes to the patient's nose is what you put inside the bag, along with the patient's leg. Then you tape it right real good to make sure it's sealed. Then you turn the oxygen to 4 liters.
The pipe goes in, so you tape the entire the pipe and the end of the bag on you wrap it on the patient.
Yeah, you down the patient's leg. Yeah, like maybe halfway to the calf or right above the knee or below the knee, and you just wrap it real tight with some tape.
When we're talking, when the bag is full, you turn it off.
No. You stay. The oxygen has to stay there continuously for 45 minutes. You cannot turn it off.
You perforate the bag to enable escape. Otherwise, it will blow up.
No, it's not going to blow off. I do it all the time. It's not going to blow up. See, because I have the gift of, if I see something, somebody brings an expensive machine and demonstrates for me, my next step is how can I make it cheaper? So I do this all the time. I've been doing this since 1997 when I first saw the technology. I've been doing it. There's no person that exploded yet. The only thing you have to tell them not to smoke. They cannot have the bag and go light a cigarette, it'll blow up. You know what I mean? You know what I mean? Somebody has the oxygen in the bag, make sure they don't go light up a cigarette. If you light up a cigarette, it will blow up. You know, there will be charcoal. So make sure they don't have those no heat source, smoking or any matches around that area when they're on the oxygen. But the bag oxygen goes on continuously at 4 liters for 45 minutes.
Do a video.
Yeah, we'll do a video. We'll do a video today and send you a video so you can actually see it.
Sir, if I may speak, the
Yes.
explosion we're talking about is not fire explosion. We're talking about the bag rupturing under pressure.
It's not. It's not going to rupture. It's not going to rupture. Just get a good plastic trash bag, clear trash bag, not too heavy in terms of texture.
Because they think it's sealed.
It's not. It does not explode. Trust me. I mean, I've been doing all this time. It's not explode. I've not seen one explode.
It won't absorb the oxygen.
Well, you get more oxygen within that chamber. It's called topical oxygen within that chamber. So your tissue is being exposed to a high concentration of oxygen, so which helps with wound healing. Yeah, they have the same device, but you will pay like $3,000 for one session to use the device. You know, you can buy it, but why pay $3,000 when you can do it as cheap as $5? You know, so it doesn't hurt, and it's easy to do. And the question is, how can we make the bag? How can you get your bag so you have your dependable bag system that you have? But the concept is the same, you know. But the bags I use just clear plastic bag and trash bag, clean trash bag, but clear, but not too heavy. It doesn't. Once you seal it nicely, it doesn't explode. It doesn't do anything. I've used it fast since 1997.
Although when within 45 minutes before it get full, it may take up to that 45 minutes because when you start,
it gets full in about 2 minutes. It gets full in about 2 minutes. You will see once you put it on, the bag will expand almost immediately, like a big bubble. Okay, then your patient stays there for 45 minutes. It's not going to explode. Trust me. I've not seen an explosion.
What is the rate of the oxygen?
4 liters per minute. 4 liters per minute is the maximum you can go. It will not explode. Yeah. I will have my medical student and I demonstrate it for you later today. Okay. We'll do a video so you can actually see it. Okay. Yeah. All right. Okay. Any further questions?
Sir,
Yeah.
just situations where hyperbaric oxygen is better than wound vac.
Well, the wound vac is when you try to improve. The wound vac is good when you have a lot of fluid drainage in the wound. You want to suck. You don't want the fluid just stay in the wound. The wound vac is excellent for that. The wound vac also creates granulation tissue. So sometimes I can debride a wound to the level of bone. Then I put a wound vac on it, and in about 2 weeks or so, you see granulation tissue of the bone. So wound vac helps. They work by 2 different means. The hyperbaric oxygen gets more oxygen to the wound. Sometimes you can do a combination, do hyperbaric oxygen and turn around and finish that and put a wound vac that can go home. So you can mix, but you cannot put both at the same time because the oxygen goes with positive pressure and the hyperbaric oxygen, the wound vac goes with negative pressure. So if you put oxygen and the wound vac, it's not going to work in the same system because they're dipolar opposite. Okay. The wound vac is a negative pressure system.
If you are to use them concurrently for a treatment of patient, you may use the wound vac when do you have to use the 45 minutes
Yeah, you can use the hyperbaric oxygen first. After 45 minutes, and you want to go home, then you can put a wound vac. You put a wound after oxygen, you can put a wound vac, and it can go home. Yes.
Okay.
But you cannot use both at the same time because if you put the oxygen and the wound vac at the same time, the wound vac is not gonna suck because wound vac works by negative pressure. The oxygen works by positive pressure, so the sponge of wound vac would not suck. Yeah, yeah. I'll demonstrate it for you, no problem. Okay. Any further questions? I have a bunch of patients now waiting for me to see, so I guess
we are very grateful. We are very grateful.
All right.
Thank you, sir.
Yeah, so I'll be in touch and I will demonstrate later on. My young doctor, Christo, my other doctor, Abu, will demonstrate the oxygen therapy for you on video. Okay, we'll send a video to you, doctor. Okay.
Thank you.
Thank you very much.
Thank
Sir.
you. All right. Have a good day. Bye-bye.
She called for you. She said it's not non-emergent whenever you need.
Okay, bye now.
Bye.
Do you want your charges? Your charges?
It's amazing.
Right exposition.
Hi.
All right, bye-bye.
All right, bye.
See you next month.
Thank you. Thank you.
All right.
Bye.
Bye.
Yes.
You're coming after, right?
All right.
Mm.